I'd like to thank everyone in the audience here who came to see our presentation about T2 Candida's role in the early detection of candidiasis. We have two excellent speakers today. First, we'll have Dr. Michael Veve. He's a clinical associate professor of pharmacy practice at Wayne State University and a clinical infectious diseases pharmacist at Henry Ford Hospital in Detroit, Michigan. Dr. Veve has authored published works on a variety of antimicrobial stewardship research topics, including implementation and assessment of novel antimicrobial stewardship interventions. We also have with us today Dr. Kaylee Caniff. She's currently completing her postdoctoral research fellowship in infectious diseases health outcomes at Wayne State University in Detroit. Dr. Caniff has published research on novel therapeutics for multi-drug resistant organisms and antimicrobial stewardship interventions to improve patient outcomes. Again, thanks to all for your attendance, and without further delay, the presentation.
Good morning, everyone. How's it going? I first want to just say thanks to T2 Biosystems for supporting myself and also Kaylee to present today about T2 Candida. So I am, as Evan kind of introduced, I am a clinical pharmacist, and I'm here to talk a little bit about how we utilize Candida, or the T2 Candida test, at a large urban health system, and kind of some of the nit and grit of implementation of the T2 Candida test at Henry Ford in Detroit. So my objectives, you can kind of read them up there, but it's to compare T2 Candida to conventional Candida species identification methods, identify the potential role of T2 Candida in antifungal stewardship, and also to describe some of the real-world data that my group has kind of put out there into the scientific literature, and also compare some subsequent outcomes in patients with Candidemia. And I have a very short amount of time to do all this, so I'm looking forward to kind of speaking a little bit more about that and hopefully complementing the next speaker's discussion. So this is probably a slide that many of you are familiar with, and from the Kevin Gary's group out in Houston, some early 2006 data assessing the time to antifungal therapy initiation and subsequent mortality. And this is a real challenge in treating Candidemia and invasive candidiasis. And you can see here, for each day delay from the date of the initial positive culture, you can see about a 10% increase in mortality. And this is, of course, looking at fluconazole initiation in susceptible isolates, but it just kind of paints the picture there in the antifungal space about how important it is to identify these species early and rapidly and get them active therapy. So, it really is challenging as an antimicrobial stewardship pharmacist to kind of weigh the risk of delaying therapy in the patient that is at risk for Candidemia and invasive candidiasis, but also the risk of antifungal overuse. And I say that because, in present day, a lot of Candidas, there's more and more proportions of Candida species that are becoming resistant to azoles or susceptible dose-dependent to azoles, cross-resistance, and really it's a challenge to identify these patients early, but in the patient that does not have invasive candidiasis, rapidly de-escalating therapy and preserving some of those broad-spectrum antifungals for patients that need it. And we know there's several new antifungal products in kind of development, and some longer-acting products where I think this is going to be more of a problem as we move over time. And I think that's kind of where rapid diagnostic tests can fit in and kind of describe the role of the clinician in early identification of invasive candidiasis. So I wanted to briefly introduce some of the rapid diagnostic tests for invasive candidiasis, and our old friend 1,3-beta-D-glucan, also known as the Fungitel test. And this is a test that detects the component of various fungal cell walls, not just for Candida species, so Aspergillus species and some other fungus. And this is a test that's obtained from serum or plasma. There's some sensitivity and specificity data that's there. But really, when the end user gets these data from the microbiology lab, generally it's going to be presented in a negative, indeterminate, or positive test. And this is how the clinicians really will weigh the risk-benefit of continuing or starting antifungal therapy in a lot of patients. And the problem with this is really the testing time kind of contributes to that delay in active therapy. And you can kind of see there 8 to 12 hours after specimen receipt, and oftentimes this is a send-out lab, and there's kind of that additional delay in those patients that need early identification. So on the flip side, the T2MR or T2 magnetic resonance, T2 Candida, is really unique and interesting technology that kind of combines nuclear medicine and magnetic resonance with polymerase chain reaction identification of Candida DNA directly from whole blood. So the great thing that me as a stewardship pharmacist really loves about this test is we can identify if a patient has Candida in their blood very, very early into their disease state. And we don't need a positive culture, positive blood culture, in order to run that positive test like some of the other conventional polymerase chain reaction tests. You can kind of see the comparison of sensitivity and specificity, very sensitive and specific to Candida species. And the interpretation seems more useful to me. Again, positive or negative for the following, and they're grouped based off of the types of typical susceptibility patterns we would see for Candida albicans, tropicalis, Prapsilosis, and then Crucii and glabrata. And really, kind of the chef's kiss here is the testing time is so rapidly improved, 3 to 5 hours from a turnaround time. It really can make some significant change in a patient who's at risk or has invasive candidiasis or candidemia. So in 2015, a group of stakeholders at my health system, including clinical microbiology, infectious diseases clinicians, infectious diseases pharmacy, kind of reevaluated our practice for management of invasive candidiasis and candidemia. And I wanted to showcase kind of our old practice and policy, if you will. And this was pre-implementation of the T2MR, and I just want to showcase some of the differences. We have, who is the population that would benefit from empiric echinocandin therapy and empiric antifungal therapy, and we define those historically as patients who are persistently septic for at least 72 hours of antibiotic use. And we've also leveraged the Candida score, which kind of assesses a patient using a point system of who would be at risk for invasive candidiasis, and kind of leverage a score of 3 or more as a trigger to initiate our antifungal therapy, which is an echinocandin. We would send 2 different beta-D-glucan tests, as well as concomitant blood cultures to hopefully identify the organism with susceptibility. And if it was a positive fungitel, then we kind of contributed to this to be a likely invasive candidiasis and continue the antifungal. And if it was negative, to discontinue the antifungal. And hopefully, with the previous slide, you can see what the problem is there, is that this is a significant delay in identification, and in patients that do have empiric therapy started, it may be several days before we get a negative test, and that can be a real challenge. So in 2017, those same stakeholders decided to implement the T2 magnetic resonance to really have a better and more efficient way to identify and treat patients with invasive candidiasis. So really a lot of the pathway is the same. Persistently septic for 72 hours of antibiotic therapy, Candida score of at least 3 or more. Those would be the patients that we initiate initial antifungal therapy or echinocandin. And what's really great about what our stewardship team has done is we package initial antifungal therapy with the T2MR, so that we'll have, those at-risk patients will have really within the same day, is this patient infected or not. We do also send concomitant blood cultures, and you can see it's kind of the same story there. Positive test, continue your antifungal. Negative test, discontinue the antifungal. And it's really been a pleasure to use this test because of the buy-in and the support of really our intensive care colleagues, and really understanding the value of the T2 for that antifungal stewardship. So I did want to showcase, our electronic health record. If a prescriber is going to place an order for an echinocandin here, you can kind of see there's a notation to please order or repeat blood cultures to document clearance. Really, we want that for more susceptibilities because of the qualitative nature of the T2 Candida and not having those susceptibilities always. And at the very bottom of the screen there, you see that the Candida T2 is appended to our kind of candidate order. So it really is kind of a nice way to ensure that patients are being tested and ensures our stewardship team the ability to de-escalate or stop an unnecessary antifungal therapy really within the same day. So we did want to talk about the overview of how we actually implemented the T2 Candida assay, and it really takes a village to do this, and there are of course some bumps and bruises along the way. So education was primarily handled by our antimicrobial stewardship program, which includes infectious diseases pharmacists, microbiologists, infectious diseases clinicians, kind of the same group of stakeholders there. And really we're trying to target the areas of our health system and hospital that kind of house those highest risk patients, right? Patients in the intensive care unit, patients in with transplant organ, solid organ transplant, or other hematological patients, and providing that education to that audience. So physicians, nursing, particularly when talking about the nuances of collecting and running those T2 Candida assay tests, and also our pharmacists who are bedside rounders and taking care of these patients on a daily basis. So some of that education was accomplished through newsletters, meetings, also educational opportunities during rounds when these patients are getting taken care of. And really the emphasis was, when do we test, who's the population at risk, proper sample collection, and the clinical implications of what that test actually means when you get a negative T2 Candida or a positive. What should we be doing there? Of course, our great laboratory colleagues implemented the T2MR in November of 2015 and eventually phased the Fungitel out because of the utility and rapid turnaround time of this test as an in-house test instead of a send-out lab. And then, as I mentioned and showcased on the previous slide, really talking more about our clinical pharmacy and our stewardship pharmacy workflow. Our kind of candidate order entry is appended to an infectious diseases consult, so we make sure that these patients are being seen, as well as the T2MR. And what's really great about our stewardship workflow is that there's a real-time alert for our stewardship program pharmacists to kind of react to these positive tests or negative tests to kind of support that antifungal stewardship. So I did want to show this in brief about the time course of suspected invasive candidiasis. Right, we send our antifungal, send the RDT, rapid diagnostic test T2 Candida, get that result, and then discontinue, de-escalate, or continue the antifungal. And so we can kind of see what that test turnaround time is, and also the duration of preemptive therapy before we can kind of make some of those decisions. And why am I showing that is because Christian Gill, a former Henry Ford Hospital infectious diseases pharmacy resident, actually evaluated this same thing, comparing our beta-D-glucan to the T2MR. And you can see there's a pretty rapid and significant increase in the test turnaround time that was found to be statistically significant. So a lot of times these are actionable within that same day of the test initially being ran and processed by the microbiology lab. So, there's also been some discussion about the sensitivity and specificity of blood cultures, and with the adaptation and kind of enhancement of blood cultures, is there really still a role for the T2 Candida? Are these blood cultures more sensitive and specific? And I think that's a great question that we tried to present and showcase at last year's ID Week from Dr. Navina Burke and colleagues. And you can kind of see here, these are patients that had a Candida T2 positive and blood culture positive, comparing two different types of blood culture systems, the VersaTrek and the Bactiller Virtuo. And even though that our microbiology lab switched over to more sensitive and specific cultures, blood cultures, you can kind of still see there's a significant difference in the identification of Candida species using the T2 Candida. So we still do feel that this is a really valuable test for us, even in the addition and development of some more sensitive blood cultures. But, it's not, like I mentioned, there's some bumps and bruises along the way of implementing really anything, not just specific to this rapid diagnostic test, but how can we enhance, how can we better educate? And, our stewardship program will routinely do medication use evaluations. And even though this isn't necessarily a medication, this is more of a laboratory RDT use evaluation, In 2019, we kind of performed a little snapshot cross-section of how the T2 test was used at our health system. And from February to August 2019, there were almost 700 T2 tests that were ordered. Only 5% were positive within that time frame. 77% were done in the ICU, and unfortunately, 84% did not meet institutional criteria for sending the T2 MR. And that's kind of a big problem from a stewardship perspective, because are we overusing this really valuable laboratory test? So, I think this leads to process improvement and enhancement of how we utilize and position the T2 Candida. This led to restriction of the test in our ICU patients only. There's a few exceptions to that in patients who are immunocompromised or solid organ or other heme disease. We noticed that there wasn't always instances where the blood cultures were ordered concomitantly. We don't want to order T2 Candida in patients that already have culture-confirmed invasive candidiasis. That's not really an efficient or lean process measure. And if negative, we actually built in kind of a hard stop to prevent repeat ordering of the Candida T2 test within 7 days, and not using T2 as a test of cure in the majority of these patients. So overall, to summarize, I think T2 is very valuable, but it is an important stewardship component to measure and evaluate how the test is being used to kind of tweak things here and there and get better buy-in by the stakeholders who take care of these patients. So some of the learning experiences from the T2 Candida implementation, it's really, really important to get all of the stakeholders involved: intensivists, critical care providers, clinical microbiologists and microtech laboratory specialists, pharmacy, infectious diseases pharmacy, intensive care pharmacy, transplant pharmacy. These are the folks that are making those decisions again, as well as nursing and emphasizing appropriate sample collection and how to make sure that those samples can be accurately processed. Really emphasize continuous monitoring of the test performance at your site if you're thinking about implementing this or already have it. And really, I think it's a great tool because of the buy-in that we have with our intensivist. Really, there's quite rapid de-escalation of initial antifungal therapy. There's really, we've had the whole team on board as far as the utility of this test at this point in time. And it's really a unique rapid diagnostic test in that manner compared to some of the other ones that are available at our health system, as just being really, really efficient at doing great antifungal stewardship. I did want to acknowledge the team of pharmacists and other clinicians and microbiology specialists, Rachel Kenny, George Allen Godden, Christian Gill, and Lenoche Samuel, for their help. And a lot of the data presented today are from slide sets that have been kind of cobbled together over years of implementation of this test. And thanks for your attention. I hope you found that this little tidbit of our experience helpful if you're thinking about the T2 Candida test.
All right, so thank you everyone for joining us today. So now I'm going to build off of Mike's presentation and talk about how Henry Ford's approach can be compared to traditional blood culture methods of diagnosis of candidemia. And I'm going to apply a novel outcome analysis to these patients. So I'm going to discuss some limitations of conventional outcome analyses when looking at laboratory diagnostic strategies in patients with candidemia. And then again, I'm going to apply a novel analysis called a desirability of outcome ranking analysis to compare patients that were diagnosed with candidemia by the T2 Candida panel as part of the stewardship approach that Henry Ford uses to patients who were diagnosed by a traditional blood culture method. And then finally, I'm going to talk about the overall clinical benefits of using T2 in practice. So we know that candidemia is quite burdensome within the intensive care unit, and the intensive care unit has in fact been identified as an independent risk factor for the development of candidemia. And the ICU really sets up the perfect storm for these patients to develop this infection. They're often immunocompromised, exposed to broad spectrum antimicrobials, and have breakdown of immunologic barriers. So once patients acquire this infection, it has quite a high mortality rate of 20 to 40%. It can increase the ICU length of stay by an average of 13 days and is associated with significant increases in healthcare costs. So fortunately, we now have a new tool in our toolbox to manage these patients, and that is the T2 Candida panel, which is a fully automated rapid diagnostic platform and utilizes the T2 magnetic resonance technology, which is like MRI technology, but on a miniaturized scale. And as my colleague pointed out, we are able to diagnose patients with the 5 most common species of Candida, and these account for over 90% of infections. So we know from a previous clinical trial that there are several benefits to utilizing the T2 Candida panel compared to traditional blood culture. Time to species identification is much sooner, so this allows for faster targeted therapy. It also has very high sensitivity and specificity. It's much more sensitive than blood cultures, especially if the patient has previously been exposed to antifungal treatment. And then finally, it has a very high negative predictive value. So this gives us the potential to discontinue empiric antifungal therapy in patients with negative results. However, no one has answered the question yet, can T2 Candida improve mortality in critically ill patients with candidemia compared to using a traditional blood culture approach? So my colleagues and I at Wayne State sought to conduct a real-world multi-center evaluation of the T2 Candida panel compared to traditional blood cultures in patients with candidemia. We recruited 14 hospitals that were matched by region, teaching affiliation, trauma level, and size, with a target enrollment of 500 intensive care unit patients. And again, we were comparing patients that were diagnosed with the T2 Candida panel to those diagnosed by blood culture for the primary outcome of 30-day all-cause mortality. So the statistical methods that we use include descriptive statistics and comparative analyses, and then as I'll get into later in this presentation, we applied a door analysis and adjusted for confounders using inverse probability treatment weighting. So to be included in this study, patients had to be adults that were diagnosed with candidemia and then either in the ICU at time of diagnosis or admitted to the ICU within 72 hours of a positive result. We excluded vulnerable populations as well as patients that were COVID-19 positive or had a bacterial bloodstream co-infection. So we conducted an interim analysis at a little over 300 cases, and these are the results for time to antifungal therapy initiation. And as you can see, the median time to therapy start is much sooner in the T2 Candida patients at a median of 5 hours versus 42 hours in the blood culture group. However, we didn't find that this translated to a mortality benefit. As you can see here, the mortality rate remained around 36 to 37% in both groups. So although this study was not yet powered at this point, there were no trends in mortality benefit observed with the use of the T2 Candida panel, despite having a much faster initiation of treatment. So why could this be? Well, we think there are a couple different factors at play. So firstly, over time, the patients that have developed candidemia have become more complex compared to earlier trials like my colleague presented. So now patients are more likely to be receiving immunosuppressive therapies either for the treatment of malignancies as well as for solid organ transplant. And we've also had a shift in practice over time as well. So echinocandins are now considered the first-line agent in intensive care unit patients, and this may have some survival benefit even if started later. So overall, we think that 30-day mortality is not really reflective of T2 Candida's potential clinical benefit. So we decided to look at the data a little bit differently by using a desirability of outcome ranking analysis, or DOR analysis. So this is a novel method for analyzing outcomes data that was developed by the Antibiotic Resistance Leadership Group in 2015. And in this analysis, patients are classified by their overall clinical outcome, which accounts for benefits and harms simultaneously. And to date, DOR analyses have been applied in over 12 clinical trials, and this continues to grow. So to give you a little bit more about what this DOR analysis is, it utilizes a DOR scale as the primary outcome, and there's an example of this on the right. So patients are assigned a rank based on their overall outcome. So this is a mutually exclusive rank So here we have the best possible rank is 1, meaning that the patient survived and they did not have any adverse events. The worst possible rank in this example is 5, or experiencing death within the study time period. And then in between at levels 2 through 4, the patient was alive, but they experienced 1 or more adverse events. So after patients are assigned their rank, the distribution of rankings are compared between the groups, and this gives us our better door probability. So what this means is if you were to randomly select a patient from your treatment group, what is the probability that they had a better overall outcome compared to the control group? So if the interventions are equal, this probability will be around 50%, but if the treatment intervention is better, it will be greater than 50%. So we piloted this door analysis with 2 sites from our overall larger study, the first being the Detroit Medical Center and the second being Henry Ford Health. And we chose these 2 sites due to our access to the medical charts, as well as to remove variation in T2 Candida and antifungal use, as we found that each site was utilizing this test a little bit differently. So my colleague introduced Henry Ford Health a little bit, so I'll tell you a little bit more about the Detroit Medical Center, our blood culture site. So both of these health systems serve urban populations within Detroit. They both have level 1 trauma centers and academic affiliations. Importantly, at the Detroit Medical Center, there is no policy in place regarding blood culture draw and antifungal initiation compared to Henry Ford, which has their T2 Candida panel along with antifungal initiation as part of a stewardship approach. So when conducting this analysis, there has not previously been a door analysis done in this population, so we had to build ours from scratch. So we consulted some experts within Candidemia and some experts that are conducting door analyses in different arenas, and this is ultimately what we came up with. So our door scale has 4 different levels, 1 being the best outcome with the patient being alive with no deleterious events occurring. And then doors level 2 and 3, the patient was alive at 30 days but had 1 or 2 deleterious events. And then finally, the worst possible outcome being 30-day mortality. So we define the deleterious events as 2 different types. So the first being the patient experiencing an infectious complication, and the second being the patient experiencing treatment failure, defined on the slide. So our baseline demographics you can see here. So the median age patients were around 62 years old. There were some racial and ethnicity differences between the 2 sites. And there was also a difference in illness severity. So the patients at the Detroit Medical Center had a higher Apache 2 score at the time of blood culture compared to the patients at Henry Ford. But there was no difference in overall comorbidity burden and the presence of an immunocompromising condition. We also saw some differences between organism distribution at the two sites. So Henry Ford had a higher frequency of Candida albicans and tropicalis compared to the Detroit Medical Center, which has a higher frequency of Krusei and glabrata. Now looking at infectious management in these 2 groups, so you can see that most of these patients at both sites are receiving an infectious diseases consult, and then a similar frequency are receiving a source control procedure, an eye exam, and an echocardiogram. Now moving on to therapy, so you can see here that again we're seeing a difference in time to therapy initiation. So therapy was initiated at a median of 43 hours at the Detroit Medical Center versus 3 hours at Henry Ford. And we're also seeing differences in empiric therapy administration. So only 23% of patients at the Detroit Medical Center were receiving empiric therapy compared to over half at Henry Ford. And this is due to their approach that they take with ordering the T2 Candida panel at the time of empiric therapy start. And then looking at targeted therapies, so most of these patients in both groups were receiving an echinocandin. There was a higher frequency of patients receiving fluconazole at Henry Ford, and this is probably due to the fact that most of these patients were being stepped down to fluconazole after an initial echinocandin course, and then also they had a higher frequency of Candida albicans or tropicalis. So now looking at the clinical outcomes, so we're seeing some differences in the occurrence of infectious complication. So almost half of patients at the Detroit Medical Center were experiencing an infectious complication compared to 25% at Henry Ford. Around 13% experienced treatment failure at the DMC compared to 4% at Henry Ford, and this was significantly different. And then again, we're not seeing any difference in 30-day mortality when comparing these two sites, similar to the overall study. So now looking at the DOR analysis. So this provides a breakdown of each of the DOR levels by treatment group. So you can see around 52% of patients at Henry Ford were alive at 30 days and they did not experience any complications. 15% were alive with one deleterious event, and then 33% met that 30-day mortality outcome. Compared to the Detroit Medical Center, where 31% of patients were alive without an event occurring, 28% were alive with one event, 4% alive with two, and then 37% meaning that 30-day mortality outcome. So this gives us our DOR probability. So the probability of having a better outcome if a patient were to be randomly assigned to T2 Candida is 58%, and this was significant. So as I noted, there were some differences in some of those baseline factors. So we applied inverse probability treatment weighting to our DOR analysis, and similarly, we're finding that the probability of having a better outcome if assigned to T2 Candida is around 58%. So in summary, the DOR analysis really allowed for a more nuanced and global assessment of outcomes in patients with Candidemia. And use of T2 Candida within an antifungal stewardship policy was associated with an overall better outcome compared to diagnosis by blood culture alone. There are some limitations to this study, so we omitted cases that had a negative T2 Candida result or a negative blood culture result, and it was exploratory, so this is the first time a DOR analysis has been applied in this setting. So next steps would be to validate this with a larger population and also identify the optimal use of T2 Candida in practice. So Henry Ford's use is just one example of how this can beneficially be used, but there are other potential ways that we can use it to optimize patient outcomes. So I'd like to thank all of my collaborators on this project, and I'll now take any questions. Thank you.